time, I was a third-year resident in internal medicine, and they assigned me to be charge resident of the Charity Hospital emergency room. And Charity Hospital at the time was one of the largest hospitals, the charity hospitals in America. And it was particularly active on Friday and Saturday nights because we had a lot of gunshot wounds and stab wounds and that type of thing, trauma. Now, I was assigned during the month of July, which has a lot of significance, because come July 1, everybody is new at their position. For instance, if you're a medical student who just graduated, became a doctor May 23rd, well, you start your internship July 1. If you were an intern on July 1, you become a first-year resident. Everybody moves up one post July 1. That means that everybody is new at whatever it is they're doing. Okay? So, being charge resident of the ER, you're placed in charge of not only the nurses, but all of the doctors, most of whom are interns. And on July 1, they are brand spanking new interns. Okay? So this is the first time they're actually responsible themselves for caring for patients. So, at the time, the Charity Hospital ER was subdivided into 4 regions. The medical ER, people who came in with medical problems like an acute MI or congestive heart failure or diabetes, was called the West Admit Room. Okay. The surgical component was called the Accident Room. There was a pediatric ER, which they referred to simply as the PER, and there was an OBGYN section that they referred to as the cockpit. Okay, so those were the 4 areas of the charity emergency room. Now, in the back of the hospital was a turnaround where ambulances and other vehicles dropped off patients. Just inside of that turnaround, inside the building, was a triage station where we assigned an intern. The intern would be the first to evaluate that new patient coming in, and he would fill out a brief, record assessment, and then assign the patient to one of those 4 stations. Okay, so the patient was immediately swept to the accident room, the West Admit room, the PER, or the cockpit, wherever it was. Okay, so this was the first week of July, and as charge resident, 2 rules. Number 1, you don't have time to evaluate every patient who comes in yourself. There's just too many people. Your role is one of a supervisory role, to make sure everything's running smoothly, okay? To make sure that every station is manned, that there's an intern assigned to every bed, and this is a large ER, so you may have like 40 beds, okay? They all have to be covered. But as the charge resident, you can't see every patient, it's just impossible. Secondly, your charge is to focus on the living. Once a patient dies, you have to move on. Okay, that's just the way it is. Sad but true. Okay, so one particular evening, it was like a Saturday night, the intern from the triage area comes up to me and says, Dr. Benner, we have a patient I think is dead on arrival.
I remember this story now.
Okay, so I said, okay, no evidence of consciousness, no signs of life, no pulse, can't hear any heartbeats, no blood pressure. No, this guy's dead. I said, fine. Someone who is either dead on arrival or dies within 24 hours of admission, by law, they're a coroner's case. In a charity hospital, it mandates that they receive an autopsy. Okay? So when he came up to me and told me this guy had a stab wound, now that question I asked him, said, well, where was the stab wound? He said, I couldn't find it. He said that the guy's dead. So again, you move on to the living. So I had to call, though, the pathology resident on call and say, listen, we have a patient presented dead on arrival, will require an autopsy. They have 24 hours to do the autopsy. So this guy, the pathologist on call, his name was Greg. He was a friend of mine. He had just finished eating down in the hospital cafeteria. which just coincidentally was across the hallway from the morgue. I don't think it was coincidental that every time someone died, the next day we had liver in the cafeteria. But that's just my opinion. That someday there was a link. But anyway, so Greg had finished eating, and he said, I was going to go home. He said, and at first he said, maybe I'll do this first thing tomorrow morning. I said, that'd be fine. And then at the last minute, he said, no. He said, let me knock this out now. He says, have the intern send someone down with the body. Okay, so we're going to deliver the body down to the morgue. Okay. When the pathologist makes the initial incision for the autopsy, two things you need to know. It's a Y incision down the chest, where the vertical part of the Y splits the sternum. And secondly, the tools that he uses are not sterile. Okay? It's not like an operating room where the tools have to be sterile. You have to have a germ-free environment, not the underwater. Because these people are dead. We're not trying to save them. So when he makes this Y incision and cuts through the sternum, remember that up against the back of the sternum is the parietal layer of the pericardium. So he splits the parietal layer of the pericardium when he's cutting through the sternum. And when he does so, there's a gush of blood that comes out from the pericardial cavity, the sac. And with that, he can see the heart suddenly start beating vigorously.
Oh my God.
And the guy sits up. Okay? So it scared him a little bit. And so he calls me and he says, Bob, this guy's alive.
Oh my God.
So I said, well, we'll send him on up. We'll take care of him.
Oh my God.
All right, so then I found the intern and I said, we need to go back and look at that patient that you accepted. Okay? And so the first thing I said was, what was the story? He said, a stab wound. So it turns out that it was an ice pick. Because if you looked in the subxiphoid space, there was a little bitty laceration. But it was so small that when the edges came back together, coapted, it was hard to see. But it was the entrance to an ice pick. And that ice pick had come up like this into the heart. Okay? It created a tunnel through the free wall of the heart such that blood from the ventricle began to collect within the pericardial sac. And as that blood collected, it compressed the ventricles so that during diastole, when the ventricles were supposed to relax and fill with blood, they couldn't fill with very much blood. So, although the heart was still beating, because it was ejecting much less blood than is typical, the patient wasn't generating a significant blood pressure to maintain cerebral perfusion. So he lost consciousness. Now, with all that blood collected within the pericardial sac, when he went to listen with the stethoscope, that pericardial hemorrhage, what we call a cardiac tamponade, it kind of insulated the sound so that you couldn't hear him. So when he listened with the stethoscope, he didn't hear any heart sounds. Unless you have a blood pressure of about 80, when you listen with the stethoscope, you're not going to hear any cry cough sounds. You can't feel a pulse either. And so he couldn't hear heart sounds. He couldn't, the guy had to be breathing shallowly, but he didn't appreciate it. So he didn't hear heart sounds. He couldn't palpate or hear or auscultate a blood pressure. He thought the guy was dead. But in fact, the guy had a cardiac tamponade, and once this pressure created by the blood in the pericardial sac was relieved, then the heart could fill up more completely and generate a better blood pressure. In which case the guy woke up and sat up.
So he was still getting some oxygen to his brain?
Yes!
Okay.
Yes. Now, the funny thing is that had he waited till the next morning to do the autopsy, the guy would have been dead, and no one would have known that, in fact, he was alive at the time of presentation. So I oftentimes say that life many, many times just hinges on little threads. It just hangs by a thread. It's just a twist of fate sometimes that separates life from death. You know, this guy, had Greg decided to do this the next day, the guy would have been dead. Nobody would have known the difference. The only reason he was alive was at the end of that conversation, Greg said, Well, let me knock it out now. Okay? So sometimes life really does hang by a thread. The funny thing is, at Charity Hospital, you had not individual rooms, but you had wards where you had like 12 beds in each ward. And when patients would come in to see some of the other people, and he would love to say, "Yeah, I woke in the morgue." You know, they thought I was dead. And the truth is, people thought he was crazy, but it was true. He did wake up in the morgue. And in fact, he stayed in the hospital for 6 weeks because they don't use sterile instruments. He developed a mediastinal infection, which we treated with 6 weeks of IV antibiotic therapy. And at that point, then, after we completed the therapy, we closed up the sternum, and he went home.
So he still had that scar though?
Oh yeah, he had the scar. But from then on, I used to always tease Greg that in the history of Charity Hospital, that was the first save ever by a pathologist. Pathologists never save people. They always work on people after the fact, post-mortem. But I can give lots of examples where the only reason someone is alive is because of some twist of fate, some mistake or accident that was made. That was just fortuitous for the patient. Okay. So, let's go back now to the right atrium. We said that the right atrium fills with unoxygenated blood, blood that's already given up its oxygen to various tissues within the body. Okay? So the blood is going to return to the right atrium via either the superior vena cava, the inferior vena cava, or here the coronary sinus. Okay? So this unoxygenated blood is going to fill up the right atrium. Okay? So while the ventricles are pumping blood, ejecting blood into the aorta and into the pulmonary trunk, this valve here is closed. Okay. So while the ventricles are pumping blood into the aorta and into the pulmonary artery, these valves are closed because if the ventricles are pumping, you don't want this valve to be open. If it were, then the blood would regurgitate back into the atrium. Okay. When the ventricles then go to relax, okay, this phase of the cardiac cycle where the ventricles relax is called diastole. When the ventricles go to relax, these AV valves open. And as they open, it allows the blood that's accumulated within the right atrium to enter into the right ventricle. Now, simultaneously, oxygenated blood that's returned to the left atrium is going to pass through the mitral valve and enter into the left ventricle. So during diastole, we have the movement of blood that's collected within the atrium, passing down into the ventricles. So the ventricles fill during diastole. Okay? Now, at the completion of this diastolic filling interval, the ventricles begin to contract. It means that the muscles within the free walls of the septum begin to contract. Okay? And so the ventricular chambers change shape. They start to get smaller. Okay? As the chambers get smaller, the pressure, the intraventricular pressure, increases. Okay? So if you have the same amount of blood that's present within a chamber that's getting progressively smaller, the pressure inside is going to increase. Okay? Now, So we have these chambers, these ventricular chambers that contain blood, and the chambers are beginning to contract, and pressure is beginning to build up. Okay? That pressure is exerted upon the undersurface of these valves, and it's going to force closed those AV valves. So during systole is the phase now where the ventricles contract. During systole, the buildup in pressure is going to force closed the tricuspid and the mitral valves. So during systole, these valves are going to close. Okay. Now, it's not only the free wall and the septum that are contracting during systole, but the papillary muscles are contracting too. And by contracting, it generates tension along the chordae tendineae that are attached to the edges of these cusps. This tension that's applied to the cusp prevents the cusp, when they go to close, from everting. So when these cusps go to close, they don't evert because of tension generated along the chordae tendineae. If these cusps did evert, then what would happen? Blood would regurgitate back into the upper chamber. Okay? Is everybody with me? All right. I'm going to modify this drawing in this way. I'm going to bring the plane of section all the way up to the front here so you can see the origin of the pulmonary trunk from the right ventricle.
So this is just the posterior.
This is a section here through the middle of the heart. But I want to bring this section further up so you can see the origin of the pulmonary trunk. Now, I'm going to do it through the magic of whiteboard. Okay? So here's what I'm going to do, kind of a crazy way. I'm going to eliminate this part here, erase some of these things here. But I can draw the pulmonary trunk coming off right ventricle like this.